Okay, I see that Eimear has joined us. That's wonderful because she's giving the next presentation. Dr. Kenny is a professor of medicine and the director of the Institute for Genomic Health at the Icahn School of Medicine at Mount Sinai. Eimear is the PI of one of the clinical sites of the Electronic Medical Records and Genomics, or eMERGE, network. We've invited her to give an update on the eMERGE project, and her presentation is titled Advancing Genomic Medicine Through Genome-Informed Risk Assessment. Welcome, Eimear, and thank you for being with us.
Well, thank you very much for the introduction and for inviting me here. As mentioned, I'm going to speak on behalf of the eMERGE network. Okay, so maybe start with PRS, which have been around for a long time in various guises, but really have accelerated in advancement, particularly in the last 5 years within human genetics research in arenas of not just disease prediction, but diagnostic accuracy and areas of really identifying individuals in a population where prevention and might be something to uptake. And in that way, it can be thought of as both analogous with and also orthogonal to other types of risk information that we routinely use in clinical care, such as clinical risk information or even social determinants of health that are used in clinical care today. And increasingly in the past 5 years or so, we've seen a lot of studies that have tried to integrate this information or understand the interaction between this type of information with a view to assessing the clinical utility of polygenic risk information. However, there's still a lot that is unknown about the clinical utility of polygenic risk scores for common disease. And as of today, there's still no clinical guidelines regarding the ordering of a polygenic test in clinical care. And some of this has to do with some biases within these genomic predictors that we know about. Here's one that's off-cited from a paper in 2019 led by Alicia Martin that really looks at these predictors of products of training data that's predominantly of European ancestry and shows quite elegantly that that means that there's reduced ancestry across genetic ancestries as those genetic ancestries are more and more divergent from the ancestries in the training data set. Today, we know a lot more subtlety and complexity about the forces at play here and how that interacts with the genetic architecture of disease and types of social determinants of health at play as well over the course of individual's life. Nevertheless, despite this complexity, we are still already starting to see this risk information come into clinical practice through various external vendor offerings so that patients are walking into our health system with this personalized information about themselves, and health systems are starting to struggle to understand how to integrate this information into the care of their patients. So really thinking about this is thinking about meeting a dual challenge. The first part of that challenge is, well, how do we effectively communicate complex risk information, not just to healthcare providers, but also to patients themselves, given the very personalized nature of this information, and how that can inform clinical decision-making. And to meet that, understanding the need for both standards and protocols to ensure that we're doing that in a way that's not only meeting regulatory compliance, but also appropriately bringing clinical utility and paying attention to the ethical uses of PRS in various healthcare settings. So it was really on discussion of many of these challenges in the field back in 2019 that NHGRI released this RFA for the 4th phase of funding for the existing eMERGE network, this time really focused on genomic risk assessment and management within healthcare. Of the sites that applied for that RFA, 10 were selected as clinical sites listed here on this slide. Also, the coordinating center at Vanderbilt and also clinical site partners at Duke and the Broad came together as part of the eMERGE Phase 4 network. And as we set out into this daunting task of building a whole in silico to implementation pipeline for bringing polygenic risk information into clinical care, one of the first things we did as a consortium and across several sites was to think about some of the ethical aspects of that. I'm going to point you to the study that we did at the Mount Sinai site, and this is work led by Sabrina Sukiel and Nora Abul-Hassan, where we did qualitative interviews in diverse patients and also English and Spanish speaking patients, equally balanced for male and female, to really get an in-depth assessment of perspectives of diverse patients on the use of clinical polygenic risk, particularly explaining that these tools may not work as well for people like you in your community. And nonetheless, the interest and perceived utility remain quite high within that group, although there were identified barriers and identification of potential for psychological distress that was expressed that could hinder widespread adoption. As well, most people preferred that this information was returned in person and in the context of their healthcare management. And it's these types of patient-centered insights that really helped us tailor the strategies that we started to develop for delivering PRS in the eMERGE network. So back in 2020, we started on the process to develop clinical polygenic tests for 10 conditions. This involved a lot of feasibility work and assessment work that happened initially, and then also but simultaneously considering not just the scientific robustness of a particular score, but also the clinical milieu and appropriateness of bringing clinical information for that test into clinical care, consideration of what kinds of guidelines would be developed for that and what would be the evidence behind that guidelines. There was a rigorous evaluation and optimization of these PRS that went through several rounds of review. And then finally, we selected 10 conditions among the starting out 22 that we started with to bring forward to actually stand up clinical polygenic risk tests that were both CLIA and New York State accredited. I'll just point to a few of the innovations that came along the way. This was one, and this is work led by Niall Lennon and Chris Kachulis at the Broad, where, really taking a polygenic risk from research, one of the first considerations is you're taking something that was built as a population-based test and you're implementing it as an N of 1. So we really had to think about that, particularly with regard to diverse participants we expected to recruit in our study. Long story short, a number of methods were developed to help to calibrate the variance in PRS performance across populations, and also to optimize the types of reference panels that we were using to do that. And this gives you a snapshot of the 10 conditions that were brought forward to develop PRS, starting with the validation that we did within the network across up to 4 different population groups, although we didn't meet 4 for every condition. Through the varying numbers of SNPs that go into the test, sort of gives you a nod to the complexity in our field and where we are, and the types of validation age ranges that were used. So we're building tests not just for adult populations, but also for pediatric populations. And this is some data, and I should mention this is data in a paper that's was accepted to Nature Medicine, and it will just be out on the 21st, so just not quite in time for this meeting. But that shows you the performance of the PRS in terms of how many individuals we expected to be in a high-risk group versus how many we observed. And for most of them, we're pretty close to performance in terms of the population mean. For some of them, you see for obesity and maybe type 2 diabetes, we're seeing more observations of high PRS than we initially expected. And if anybody wants to ask me about that, I can tell you why. And then, of course, we wanted to bring this polygenic risk information into clinical care, but it was very important that we did this in a very integrated way with other known risk for the particular health outcomes that we are looking at. This includes monogenic risk, and it also includes family history. So monogenic risk is measured for a subset of our conditions using monogenic screening for overlapping disorders, and family history is collected through through a tool that was developed at Duke University called MITRI. Clinical risk information we obtain several different ways through a patient survey and also through EHR mining of patient clinical records. And at the end, the product, which is the genome-informed risk assessment, looks something like this in this very simple cartoon, which is an individual gets a report for 10 conditions, or up to 10 conditions. Children get a report for 4 conditions. 11, actually, I should say, because one of the conditions doesn't have a polygenic risk attached, but does have a monogenic risk, where an individual is on the report, an individual is either at high risk, meaning they fall in a high risk group, or not high risk, meaning they can fall anywhere else on the distribution of risk for that condition. Now, I don't expect you to be able to read all the text here. I'm basically just showing you this exists. This is an example of the type of clinical report that is given to providers for each of the patients in the study. And just at a high level, it describes both the condition and an explanation of the high risk, the eMERGE network screening and risk reduction recommendations, which were developed in concert with many clinical experts across the network, and the recommendations to share with providers. And again, there's a lot of text on this screen. This is also in the paper I mentioned earlier, if you're interested to read it. But I just want to emphasize here that many of the recommendations are emphasizing healthy lifestyle improvements through counseling and education. In one case, it's around reduce triggers or share decision-making about early screening. Some of the other things we track are recommendations for laboratory tests and procedures, including imaging orders, for example, breast MRI or mammogram for breast cancer, and others that you can see here. And again, very wordy slides, but just to let you know that the report is not just provider facing, it is also patient facing. And there is significant educational material within the JIRA report that is provided at the level of patient education for any of the conditions for which the patient is deemed to be high risk. And so this risk report is integrated into a prospective study in which study staff returns the high-risk report. This is sometimes genetic counselors, sometimes PharmD, sometimes other study staff. And the report is integrated into the EHR at the various clinical sites with a notification to the provider, oftentimes a PCP, and any new health behaviors or additional screening tests or any healthcare changes, both 6 months and 12 months post-return, are both surveyed for and measured continuously by EHR surveillance. We enrolled our first participant to this study in February 2022, and we start returning our first GIRA in January 2023. So I'm not going to talk about it too much in this talk, but I do want to let you know that this entire study is powered by a quite sophisticated informatics engine, as you might imagine, across the entire network that is centralized in Vanderbilt, but really speaks to the various clinical testing sites and the back end to NHGRI Anvil, and also the other tools such as Mitri and Bodicea. And just to focus on what is of interest to this study, it's really to determine if healthcare actions are associated with the care recommendations that are given at the point of results disclosure are more common, taken up more commonly among the high-risk group than the other groups. And we're looking at a number of both clinician-adopted recommendations and patient adoption and new diagnoses. In addition to these recommendations, we are also collecting rich data around prescriptions, referrals, procedures, diagnoses, lab results, lab orders, in addition to doing both not only patient surveys, but provider surveys and understanding the attitudes of the genetic counselors in our studies. So here we are as of January 2026. So this is now almost 2 years after we started to enroll and almost a year after we started to return results in this study. And we are almost at completion of enrollment. Our goal as a network is 25,000 participants across the 10 clinical sites, and we're close to 22,000 as of the end of January. Approximately 13% are pediatric, about half are racial or ethnic minorities, about 66% female at birth, and about 12% sexual orientation minority. And I just want to point out that these beautiful slides have been generated by our colleagues Jody and Josh in the CC at Vanderbilt. And if we actually look at the report and see underneath the hood what triggers a high risk, you see it actually varies across the different conditions in our study. And in some cases, just the PRS by itself, belonging in the high risk group in the PRS distribution, would trigger that a high risk GERA report. And family history and clinical risk and other features may also be displayed in that report. For other conditions, multiple things can trigger a report, including monogenic risk, but also including family history risk, which is the case for 4 of the conditions. For one of our conditions, which is breast cancer, we actually use the Bodicea lifetime score that's integrated with monogenic, polygenic, and family history and clinical risk. And to meet high risk, you would have to be 25% lifetime risk with that score. So we have also returned nearly 6,000 GERA, 4,400-ish to adult populations, about 1,200 to pediatric populations. Of the high risk that have been returned, a majority actually are because of family history high risk. About 900 are because of PRS high risk, and about 118 are because of a pathogenic monogenic finding. And again, 71 are from Bodicea. So all in all, that means that about a third of participants in our study will receive a high risk return for one or multiple conditions. And these are how the high risk breaks down across the different conditions in our study, remembering there are different thresholds for high risk across the conditions. Some have monogenic risk, others don't, and some have independent family history high risk and others don't. And that's really what's driving a lot of the differences that you see across conditions. The conditions that we return as high risk by far are coronary heart disease and chronic kidney disease. And here's a little snapshot of how we return these results. Most of the high risk are returned one-on-one. These are often returned either via video conference, small minority in person, or sometimes by phone call. Not high risk are more often returned passively, although some can also be returned by phone call. And here's a preliminary first look at some of the outcomes. And I should say that we're really, as a network, only now at a point where we're even starting to see some of this outcome, take a look at some of this outcome. But this I really want to credit to Dr. John Connolly from CHOP, where they are taking a lead on type 1 diabetes in children. And you can start to see again, in a very, very preliminary way with very small numbers. So this is all just sort of qualitative observations at this point. But nevertheless, it gives a sort of sense of what we're starting to see, at least for type 1 diabetes, where we see in the high risk group versus the non-high risk comparator an increase in things we would expect in terms of lab tests, for example, antibody screening, and perhaps in things like referrals, so referral to endocrine given a high risk disclosure. And I wanted to end giving you more anecdotally what we're finding in our study. And this is from our site here in Mount Sinai. This is a case of a 67-year-old female participant of Puerto Rican ancestry who had a variety of comorbidities and had no previous genetic testing. She was negative for monogenic risk, but found to be both high for PRS for breast cancer, and also in the integrated risk score, the BODICEA, she was found to have about a 30% lifetime risk for breast cancer. So she was in our high risk group. Now, she already knew that she had a mother who had had a breast cancer diagnosis when she was 45, but otherwise hadn't given too much thought to this as part of her family risk. However, between the time she enrolled in the study and the time that we met her for results disclosure, her daughter at age of 45 had been diagnosed with breast cancer and actually attended this disclosure. So we were able to have more discussion about what this result meant for her, but also members of her family. And then when she went away and talked with her where PCP got the result in EPIC, they reached out directly to study staff to ask for additional information to help them understand the finding and think through the management guidelines. They also met with the patient and through shared decision making, agreed that the patient would continue to have her regularly scheduled mammogram, which was already coming up anyway, but consider after that going forward to get an MRI. So to conclude, I think what we're learning within the eMERGE network is a few things. Really one of the most remarkable achievements of this network has been the rapid and scalable way that we've built end-to-end in silico through implementation machinery that allows for the integration of GERA at 10 clinical sites nationally. Some of the considerations we've learned about earlier on in the network are really about both patient and provider attitudes, how we can calibrate and validate and stand up clinical tests for PRS that will be fairly robust across diverse ancestry groups, with the caveat that they don't perform equally across ancestry groups. Thinking a lot about the regulatory considerations, not only in developing clinical tests, but also in developing a research GERA clinical report we can use in the clinic. We've developed clinical decision support, care recommendations, and even local clinical informatics support and best practice alerts. And now in the next year and a half, thinking very carefully about how we're measuring and analyzing both primary and secondary outcomes of this study and learning a lot about providers' attitudes to this information, which is really a journey sometimes in terms of education. So thinking about future opportunities for integrating genetic risk, I mentioned what eMERGE 4 has really shown it capable of delivering in terms of building GERA and implementing them across different clinical scenarios. Thinking about how this could be extended, really it's primed to tackle even more sophisticated risk stratification schema and maybe integrate AI and machine learning into those types of schema, even in primed to consider more sophisticated data types, particularly data types we don't frequently yet measure in health systems like exposome information or methylation, and thinking also about how we could be more sophisticated in measuring outcomes and assessment tools. So with that, I just want to thank especially the people who really helped put these slides together and whose work I showed that I mentioned along the way, the many members of the CC, the Broad genotyping, Duke Mitri team, and NHGRI, and there's way too many to show, so I'll just say all the 10 clinical sites who've been working very closely together on that. And with that, I'll stop and take any questions.
Nancy, do you want to start us off?
Well, I do want to come back to that interesting observation that you observe higher genetic liability for both type 2 diabetes and obesity than you expected to see in those samples, and why you think that is?
Yeah, the type 2 diabetes and obesity is very interesting. We think it's something to do with there's just more variance at the tails of those distributions across different phenotype or across different populations that we have in our study. And so I didn't get into it, but what we're doing is we're centering both the mean and the variance in our correction. And so that's sort of, I think, pushing people into the high risk bin.
Yeah. Well, it is actually type 2 PRS is more predictive across populations than most others. So that's a little bit odd. I mean, it's a really interesting, yeah, maybe that was a particularly unnecessary thing to do for that population, but it's a really interesting observation. I'd wonder more actually about the data having some skew by, I mean, obesity does have this positive trend of the PRS over time that's maybe because of height being in the denominator, which has that negative slope over time. But yeah, very interesting.
Lisa, go ahead.
Thanks. I was just interested in hearing a little bit about outcomes with regard to, as you said, the lifestyle interventions, the education and counseling interventions. Is it premature for any results there? But what are your plans for the outcomes beyond the healthcare actions that you discussed?
Yeah, thanks for that question. So we built an extensive survey for our patients to be administered both at the disclosure and 6 months out, or prior to the disclosure and 6 months out, where we will be asking questions about various lifestyle interventions and lots of other things. So that's our main way to capture that information. It is a little early in the sense that I don't know anybody yet who's touched that and done any analysis within the network, but we're about getting there. We're starting to sort of, as you could see in the talk, we're getting upward of 5,000 plus disclosures at this point, and we've been disclosing results for over a year now. So we could, very soon in the network could start to delve into that.
Is there any chance of a longer follow-up to track beyond 6 months, which would actually, I think, constitute an innovation beyond what we've seen in other studies, looking at lifestyle that seems to be, at the, intention plus 3 months plus 6 months, and then who knows?
Yeah. So we will be following up our patients until the end of the study, so July 2026, I believe, although Rob can correct me. I'm not aware that we have another plan to follow up on it further out with the survey. And a little bit of to do that is to do just time constraint in the study. But there will be some aspects of lifestyle that we can collect by passively mining the EHR as well. So we can look to that as well.
Laura, go ahead.
So thank you for this really great presentation. I'm very excited to see how these genomically informed risk assessments are going to move out and change behavior. I have two questions. One is the science base for genetics is changing. And given this change, how are you going to decide when do you update your polygenic risk score? When do you update these tools that you're making?
That's a great question. We had lots of discussion of that within the network. Because in one sense, our hands are tied by the study design. We have, you at certain point, you have to freeze your tool that you then measure. But on the other hand, we recognize and actually kind of maybe lost out some opportunity just because there was a great tool that was just going to come out and it just wasn't there on time. And so we couldn't bring it into this study. So we're not doing it within network within the context of the prospective study. We're going to continue with the tools that we have and at the end of the study assess how they performed. However, we are working jointly with the NHGRI Primed Consortium to do an in silico analysis of both the clinical context of these PRS and if we improve them, how would that change these different features? So I think there's an opportunity to look in a more in silico frameworks, how that might affect outcomes. And actually what we're learning in eMERGE network in terms of which health outcomes are important or which features are important are things we can then feed back into the in silico work.
Mm-hmm. So, I think it's very interesting and, thinking about what the metrics are going to be of like, how much does it need to improve? How, before you change your tool, I think will be something that could be very helpful. Mm-hmm. My other comment has to do with scalability and, thinking about how are we going to really scale this? If a third of people have some type of polygenic risk information that should be returned. How are we going to return that to people and in what type of methods is, I think, really going to be a challenge for us. Our primary care providers are already stretched quite a bit.
Yeah, I think that's a really great point and probably one that keeps health systems up a lot because as I mentioned, this information is coming into health systems even if the PCPs aren't directly ordering it. I don't know that we have clear answers yet, but I certainly think the research we're doing in eMERGE is shedding light on issues of scalability. It's not our prime objective, but we're learning a lot as we go along. Certainly some of the questions that we're able to assess are due to the nature that each site is doing things slightly differently. And as I mentioned, some sites have genetic counselors returning results, some sites have clinical research coordinators doing so, some sites have PharmD. So we're learning a lot about the operational logistics around returning this information. One of the things has been quite surprising is that sort of touches this type of information is that it's hard to predict how much resource and time it will take to return a result. Something that you think is a very complex result, you call the person to tell them, they're like, oh, no, I already know that. And so it takes 5 minutes. And then something that you think is very straightforward, somebody has a lot of questions about and you're spending 40 minutes on the phone. So I think, I don't know if we have an answer today, but I certainly think that a lot of, even getting this up to scale and in 10 different health systems around the country and in all the different clinical settings is teaching us a lot about what it would take to bring this kind of information more routinely into clinical care.
Thank you.
Any other questions for Eimear? Okay, Dr. Kenny, thank you very much for spending time with us today and for that terrific presentation.